My name's Chris Olesovsky. I'm one of the cardiology residents here at St. Michael's Hospital on my echocardiography block. And today what I'm going to be presenting to you is a practical approach to grading the severity of valvular lesions with transthoracic echo. The reason why this topic kind of came up for me is I started my echo block about a week ago, and obviously at St. Michael's Hospital with all the valve interventions that we do here, having a good sense for what goes into really accurately interrogating a valve lesion and understanding how to grade it became very important as I kind of begin to work on developing my reading skills. So I'll go through this today with you guys today. So in terms of the objectives that I want to cover, first I'm going to review major indications for mitral and aortic valve interventions, because we'll see obviously the indications for operating on a valve really depend quite often on the severity of the disease. And then I'm going to review the current recommendations for classifying the severity of a few different lesions. So we're going to look at aortic stenosis, aortic regurgitation, mitral stenosis, and mitral regurgitation, and sort of take a high-level overview, looking at kind of common patterns between grading the severity in these different valve lesions. So first we'll start with aortic stenosis. So just to give a little bit of background on aortic stenosis, in terms of the general etiology, really it's important to look at the demographic of the patient that's in front of you for what the common cause of the aortic stenosis might be. If it's a younger patient, very important to look for a bicuspid valve. And I think a good tip is anytime you're looking for a bicuspid valve, really looking for any concomitant aortopathy that might be present as well. Less so relevant here, but in developing countries, rheumatic heart disease can not only affect the mitral valve, but can affect the aortic valve. So something to consider. And then in our older populations that we see for TAVIs sort of day in and day out, really calcific is the primary cause. In terms of the clinical course itself, for aortic stenosis, there's a long period of normally asymptomatic where the aortic stenosis can kind of progress and slowly worsen. And then eventually it reaches a point, typically when it reaches more of a severe category, when symptoms occur. And those symptoms are commonly angina, syncope, heart failure. And once we're seeing those symptoms, then the decision to intervene becomes a little bit clearer. And obviously it has negative prognosis for the overall outcome of the disease pathology. Not surprisingly, in terms of prevalence, aortic stenosis and the repair of an aortic valve or replacement or TAVI is the most common valve replacement worldwide. And the prevalence is estimated anywhere between 0.3 to 0.5% in the general population, and much higher in the older population. With people above 65, the prevalence listed, from what I could find, anywhere between 2 to 7%. So it's not surprising you don't really get through a day in the echo lab without seeing a number of aortic stenosis cases. In terms of class 1 indications for replacement, really it's severe symptomatic aortic stenosis, severe asymptomatic aortic stenosis with a decline in the LV function. So in this case, it's LVF less than 50%. Severe asymptomatic aortic stenosis going for other cardiac surgery, and then symptomatic low flow, low gradient AS, which we'll talk just very briefly about right now, also with a decrease in their LVEF. So this is a good sort of algorithm to go through low flow, low gradient aortic stenosis. And we'll talk about sort of the grading of severe AS in a little bit, but really we'll see on the left here, high gradient severe AS is a mean gradient over 40 with aortic valve area less than 1. We've clinched the diagnosis of severe AS right away. In low gradient AS, low flow, low gradient, we may see a gradient less than 40. We may see a Vmax less than 4, but the aortic valve area is less than 1 centimeter squared. So in this case, it's very important to then define the flow state, which we go on to look at stroke volume index. And in the case of a stroke volume index being less than 35 milliliters per meter squared, then we look at the ejection fraction. If the ejection fraction is less than 50%, this is sort of our classical low flow, low gradient AS, and we have to go on to confirm that with a dobutamine stress test. Normally, in some cases, we can actually do imaging tests to look at calcium scores, but the classical training is the dobutamine stress echo, where we give inotropes, try to increase the stroke volume. And if on the right panel here, we see once stroke volume increases, if then we still have aortic stenosis and aortic valve area less than 1, and our mean gradient and Vmax have increased to the severe range, then we've diagnosed true severe AS. Versus if giving inotropy, increasing the stroke volume, then opens up the aortic valve a little bit more and the aortic valve area is greater than 1 centimeter squared, then we're in this sort of pseudo-severe AS category. So I think just important to sort of have this algorithm in the back of our mind when we're looking at AS cases, especially when our stroke volume index is low. So now moving forward in terms of how we actually grade AS severity and what quantification tools are very important. This table goes through some of them right here. So the LVOT diameter is very important to measure. This is typically done in the 2D peristernal long axis. The measurement itself is the inner edge to the inner edge. It's taken during mid-systole. The diameter is then used to calculate the circular cross-sectional area, which we'll see is very important for a number of our calculations down the line. Next is our LVOT velocity and our aortic stenosis velocity. The LVOT velocity is typically taken in the apical 5 chamber with a pulse wave Doppler positioned just on the left ventricular side of the aortic valve. And the idea of this is through tracing the Doppler signal, we're able to get not only a velocity time integral, but then also a max velocity from the peak of this velocity curve. And we'll look at these in a little bit. Similarly, with the aortic stenosis jet velocity, this is just in a similar position, normally in an apical 5 chamber, but you can take it in apical 3 chamber, suprasternal, right peristernal. Really, you're looking for sort of the densest signal that you can capture. And this is a continuous wave Doppler. Again, through tracing the signal, we're then able to get not only a max velocity, but then also the VTI, which is important for our calculations. And then finally, I think valve anatomy is always something to look at to really get a sense for what the potential cause might be, and also get a sense for the severity itself just qualitatively. Often their peristernal long and short axis views are good senses for whether or not the aortic valve is opening effectively, and identifying the number of leaflets, assessing leaflet mobility, and looking for valve calcification. So from these measurements, we're able to calculate these parameters, which we are then able to use to help guide us in terms of grading the severity of aortic stenosis. So one is the aortic stenosis jet velocity. This is a direct measurement that's taken from the continuous wave Doppler that we've taken. The idea is that the velocity should increase through that stenotic lesion when the stenosis severity increases. And it's a very strong predictor of clinical outcomes. And relatively easy to measure. So this is an important variable to look at. Next is the mean gradient. And again, this is taken from our Doppler curves as well. Calculation is shown here, but essentially the idea is it's a pressure gradient that's calculated from the velocities using Bernoulli's equation. And then the mean gradients average from that velocity time integral curve that we trace in with our continuous wave Doppler. Then there's a number of different equations where we can estimate the aortic valve area. So the continuity equation is sort of the classical one, where we take the cross-sectional area of the LVOT with that measurement in order to estimate where we measure, we sort of estimate a circular area, and then divide that by our dimensionless valve index. So the LVOT VTI divided by the aortic VTI, multiply these together, and this gives us an aortic valve area, and really measures the effective orifice that's involved, and again, typically feasible in most cases. So these are, again, the parameters that we'll look for stenosis. So going through that in a little bit more detail, this just shows general tracing in our peristernal long axis for measuring the LVOT diameter. It's peristernal long axis zoomed inner edge to inner edge, mid-systole, and parallel adjacent to the aortic valve. And like I said, the diameter that we get here, we half it to get the radius, and then use this to calculate our cross-sectional area, estimating a circular cross-section at this point. Next is our LVOT velocity and LVOT VTI. So as I mentioned here, this is our pulse wave Doppler that's taken on the LV side, again, at the level of the LVOT. We can take a number of different samples to make sure that we're in the correct position, and you're looking for the dense curve that can then be traced. Again, this is traced during systole so that we're able to get not only the mean gradient, but also a velocity at this point as well, and a VTI that's used for a dimensionless valve index. Again, similarly, aortic stenosis, the jet velocity, same spot, except we've switched to continuous wave Doppler. It's placed in the cursor placed in the middle of the aortic valve. You trace along the mode of velocity. Again, this will give us our, the peak of this will give us our velocity, and then tracing this will give us our mean gradient. So again, as I mentioned, aortic valve anatomy is very important when we're looking at a case of possible severe AS. So these are all short axis views of the aortic valve, and we can see calcific AS on the top with mild, moderate to severe. Important to note that for TTEs, which cusp is which. So in our classic tri-leaflet, we have our right coronary cusp, and the acronym that I've always been taught is right lies north in this view. It's named according to the coronary vessel that's coming off. So the right coronary cusp possibly has the RCA coming off. The left coronary cusp has the left main coming off. And then the non-coronary cusp is at the border of between the right atrium and the left atrium, interatrial septum. So when in doubt, you can look for the septum as well and sort of try to figure out your leaflet anatomy. And why that's very important is to, again, especially in our younger patients that may be presenting with aortic stenosis, is to look for whether or not a bicuspid valve might be present. And even in some cases, much more rare, they can have unicuspid valves, quadricuspid valves, so really keeping a good sense for what the aortic anatomy is or the aortic valve anatomy is when we're seeing AS. If we do see bicuspid valve, then it's important to then classify it to make sure that we're sort of reporting exactly what we see. And we've got the Sievers classification for that. So I'll focus on the top panel here because this is for the transthoracic echo. Again, we see our RCA and left main coming off of the corresponding coronary cusp. And then it really is named according to which cusps are fused together. So if our right and left are fused together, it's type 1, right and non is type 2, and then left and non is type 3. We're able to sort of get a sense for what classification the valve is in. And then this is really our summary table. So after taking all of these measurements, we were able to get a measurement for each of these. And I think our understanding of really cutoffs for AS with TAVI are really quite clear, and often people know this quite well. But just to review it, so velocity, the max velocity of 4 meters per second, a mean gradient over 40 millimeters of mercury, a valve area less than 1, and then a dimensionless index, which is really just taken from the from the LVOT over the aortic valve, either velocity or VTI, and we can get less than 0.25 in this case, would classify severe. Knowing that aortic sclerosis is something that sometimes we see, and it's often sort of considered on the same spectrum of disease, just early progression, but in this case, it's classified as a velocity less than 2.5 meters per second. And then as we're moving through these categories, we can see that each of them are correspondingly increasing, and our valve area is correspondingly decreasing. So next, we'll cover aortic regurgitation as the next valvulation that I want to go through. So in terms of aortic regurgitation, I think it's a good way to break it down is acute and chronic. Acute aortic regurgitation, these patients are much sicker, typically you're presenting in the CCU, they might be for portable echoes, often things that can cause it are dissections, endocarditis, trauma, prosthetic valve dysfunction. Can all be things that can cause acute aortic regurgitation. Chronic aortic regurgitation can be divided into two categories, so primary aorta problem or primary valve problem. In a primary aorta problem, you were looking for aortic dilatation. A number of things can cause that: connective tissue diseases like Marfan's, having a bicuspid valve, again, are more predisposed to having aortopathies, hypertension, different infections as well. And then a primary valve problem, so similarly to the things that we were looking for with AS, calcific a valve, a bicuspid valve, rheumatic valve, or more kind of smoldering endocarditis can all present with sort of chronic aortic regurgitation. But the patient population themselves will present quite differently in terms of whether or not they're sort of an inpatient in the hospital versus maybe an outpatient. Our class 1 indications for aortic regurgitation for surgery are similar to aortic stenosis. Again, we're looking at severe symptomatic, severe asymptomatic with an EF less than 55%, or severe asymptomatic and you're going for another cardiac surgery. So quite similar to AS. And again, we noticed that entering that severe category really opens up the indication for when this should be fixed, which I think is why it's important to have a really good understanding of how it's graded. So here's the kind of chart that I use for grading aortic regurgitation. And you'll notice the top are sort of specific signs, supportive signs, and then quantitative parameters. So the top two rows really look at more qualitative features, which we'll go through individually. And then the bottom one, maybe there's not total fitting into one category or the other. Quantitative parameters can be very helpful if you have the sort of images that are needed to make these calculations to really figure out what category you're in. Similarly, if you're in a moderate to severe category, having these quantitative parameters can be very helpful as well to figure out whether or not maybe you do enter into that severe category. So one of the regions that we'll look at is jet width. And again, this is relative to the LVOT velocity or LVOT because the aortic regurgitation is going to be moving backwards. If it's less than 25% the LVOT, this is mild, more than 65%, classically severe. We look at a vena contracta as well. Again, this is a narrowest portion. We'll look at a number of different vena contractas and how to measure this. But if it's small, less than 3 centimeters, mild. If it's greater than 6 centimeters, severe. Then we can look at also diastolic flow reversal. If it's holodiastolic flow reversal through the duration of diastole, then this is a sign of severe. If it's very brief, just a jet of color, a short signal, or none at all, then this is more in keeping with mild. We also can measure pressure half time from our Doppler tracings, which we'll show. If it's high, more than 500 milliseconds, then this is more mild. Less than 200 is severe. And then also important to look at the actual overall LV function, because typically if it's mild aortic regurgitation, we normally won't see much LV dilatation or change in the LV size, versus if it's severe and we have a lot of volume moving backwards, then we start to see that moderate LV enlargement. Can be another sign that pushes us one way or another. And then we have our quantitative parameters here. And we'll see similarities when we get into mitral regurgitation for same calculations in that case, but we look at regurgitant volume, regurgitant fraction, and the effective regurgitant orifice area. Not surprisingly, as our sort of effective regurgitant orifice area increases, if it was more than 0.3 centimeters squared, then this is our severe category. If it's smaller, less room for regurgitant flow, 0.1 centimeters is our more mild category. Similarly, our regurgitant volume looks at the amount of blood flow going back per beat, and if it's quite high, so more than 60 milliliters per beat, then this is a severe category. Less than 30 is in our mild category, and then anything in between is in that moderate range. So going through some of those values and how we take them, just to have a good understanding of how we're able to grade severity. One is the vena contracta and jet width. So classically, this can be taken. We can look at our 5-chamber apical view or parasternal long axis to have a sense for how much flow is going backwards into our LVOT to grade the jet width. And then the vena contracta is when we are starting to see a PISA, which is the area above. The vena contracta is the narrowest point, typically right at the orifice, which we measure to get a sense for how severe it is. Again, if it's larger in diameter, then this is a point towards severity. Since aortic regurgitation is a diastolic murmur, we measure this and we look for this during diastole, so at the end of the T wave, and we use color Doppler to take this. Next is holodiastolic flow reversal. So in our suprasternal views, we're able to take continuous wave and pulse wave Dopplers down our descending aorta. And what I'll draw your attention to here is, not surprisingly, during systole, we see flow going away from our probe, which we'd expect. But then during diastole, in more severe aortic regurgitation, we start to see flow towards the Doppler, and this is a point towards aortic regurgitation, especially if it's occurring through the duration of diastole here in this case. It can be a sign towards severity. We also look at color Doppler as well to see that sort of red jet moving towards the probe, and if it's occurring just as a one pulse or whether or not it's occurring through, again, the duration of diastole. This can help us get a sense for how severe the aortic regurgitation really is. Then pressure half time is a useful tool, and in terms of pressure half time, we get this from the continuous wave Doppler through the aortic valve. So it's sort of the same spot that we've taken the aortic stenosis continuous wave. In this case, we're trying to line it up with our jet of regurgitation that we're seeing to get sort of the best signal. And then once we get this, then we're able to measure the slope here, which will then spit out the pulmonary or the pressure half time. And that's really the time interval in milliseconds between the max peak gradient and the time where the gradient is half the maximal initial value. So really, once you have the slope value at this point, then we're able to calculate the pressure half time. If the slope is kind of closer to a straight line, then this points towards severity because it shows that the pressure half time is occurring faster. You have more flow backwards. If it's more of a flat line, looks like almost like a plateau, then this points towards more of a mild aortic regurgitation. And then in terms of the more quantitative measures, we have the effective regurgitant orifice area. So I thought we'd just spend a little bit of time just looking to see how this is calculated. So in terms of what we need to actually make this measurement, is the first thing we need is a PISA. And again, the PISA is sort of the dome structure that's above our vena contracta. We need to measure this so that we can then take a PISA radius for our calculation. And at this point, the image is taken, we have an Olesovsky velocity, which is used for our equation as well. And then once we have these two parameters, then we're essentially able to plug them into this equation here to get our volume flow rate, 2 pi r squared times the Olesovsky velocity. That will give us our volume flow rate. Then we need to get a max V velocity, which is taken through our, again, Doppler signal, the continuous wave Doppler. We divide these two values and we get effective regurgitant orifice area. And then when we trace this signal and get the VTI, if we multiply the ERA by the VTI, we're able to get a regurgitant volume. And again, these have specific cutoffs for aortic regurgitation and mitral regurgitation, but the idea is the same. The calculation is quite similar. I think there's a really good tool that I use to calculate this, MD Math, that goes through this very well and shows you exactly sort of the constants that you need to plug in, the variables that you need to plug in, and we'll spit this all out and even give you an idea of what category it falls into. So it can be a very helpful tool. Especially, again, in that borderline category when you're wondering about maybe severity and wanting to have some more concrete quantitative values. Now, this just brings it sort of all together. So this shows the pressure half time and also the effective regurgitant orifice area. So like I was saying, severe, we see very steep decline here. The pressure half time is going to be quite short, less than 200 milliseconds. Our effective regurgitant orifice area in this case is above 0.3, which enters our severe category. Compare that to our mild group here. So our pressure half time in this case is almost quite flat, very gentle decline slope. So it's actually 710 milliseconds. Recall that it's more than 500 is in the mild category, and then our EROA is less than 1. So typically we see a good kind of consistency across the board in this. The other factor that can sometimes be helpful is looking at the actual jet density as well, because really what we're looking at in these Doppler signals, the density should be proportional to the number of red blood cells that's going in one direction or the other. So if we have a lot of aortic regurgitation, we have a lot of blood moving backwards, then the signal should be denser. And you can sort of compare it to the forward flow. If you're seeing very a good sharp signal, then this can be another clue that maybe you're looking at more of a severe type picture, or at least a moderate picture. So all of these things are taken together. And again, this just shows that no one value is really useful in isolation. It's really looking at them in combination. So we've got our color Doppler here to look at jet width, less than 25% in this case, much more significant here in our severe. We've got our continuous wave Doppler to help us get our pressure half time. And then the pulse wave of the descending aorta, we can see again holodiastolic flow reversal here, versus in this case, maybe just a very brief period during the beginning of diastole, but certainly nothing afterwards. So more fitting in a mild aortic regurgitation. I found this table online. I think it's a really useful tool that kind of goes through everything that I've just talked about here, that really when you first see aortic regurgitation, to look for these specific criteria so that you can see visually. So vena contracta, the jet nature, the PISA, the actual signal itself, pressure half time, looking at the LV. If really you're meeting a lot of the criteria in one particular group, then I think that you can move ahead with being fairly confident in your assessment. If you're maybe 2 or 3 and there's overlap between what you're seeing, then I think a really good idea to move on to these quantitative values, especially if you do have a good PISA that can be measured, because that can really give you a good basis for what category you're in. And then again, like I was saying, if you're in that moderate category, I think it's a good practice to be doing the quantitative assessment as well, just to see if maybe you're surprised, especially if there's an eccentric jet that maybe you're not capturing fully with your Dopplers, that might enter into that moderate severe category. And severe, again, will change sort of the clinical management of these patients. So moving right along, next is mitral stenosis. So again, just looking at etiologies of mitral stenosis to start, the classical teaching is rheumatic MS, and we still see that here at St. Michael's Hospital, but often if it's the rheumatic fever is endemic to the area, then we'll see this much more often. We see this in our immigrant population as well that's coming here, but always important to be looking for. Other causes of MS, mitral annular calcification, which we'll typically see in some older population, patients that maybe have end-stage renal disease, can be more predisposed to generating sort of calcium that can then lead to MS. Radiation therapy in the past, all things to be looking for. Sometimes thing that makes these measurements challenging, and we'll get into, is oftentimes these patients are in atrial fibrillation, just due to the nature of their left atrial enlargement. They're obviously predisposed to developing AFib. And then in some cases that will make our measurements a little bit more challenging, but just to kind of note that they're quite often associated. Again, in terms of the clinical course, if this is a rheumatic type picture, normally the patient has the acute rheumatic infection that leads to inflammation in the heart. It can affect numerous valves, but classically the mitral valve. But again, I think a good teaching point is anytime you see the mitral valve involved, look for the aortic valve as well. And then after sort of the acute episode of the rheumatic fever, this chronic inflammation can then lead to significant valve changes over years, which then we see a little bit later on. Prevalence of MS, so again, it's commonly found in more patients that have immigrated from other areas where it's endemic, and it's actually more common in women as well. In terms of our overall indications for intervention, so a number of different options are involved. So one is the percutaneous mitral balloon commissurotomy. So the indication for this is severe symptomatic MS when there's favorable valve anatomy, and it's contraindicated if you have more than moderate MR, and that makes sense as you're essentially using a balloon to dilate. If you already have moderate mitral regurgitation, then you might fix one problem but worsen another. And then the class 1 indication for mitral valve surgery are, again, severe symptomatic MS with an acceptable surgical risk, or severe MS and they're planning for another CV surgery. So all reasons to go in and fix the valve in this case. So again, going right through to sort of approaches that we use to measure MS severity. So one is getting an actual measure of the valve area, and the valve area can be measured in two different ways. One is a direct measurement through planimetry, and this involves tracing the mitral orifice using our 2D echo. It's quite accurate normally, and again in our short axis here where we have a good view of the actual orifice. It's accurate, it's not always feasible, it needs a bit of experience as well in order to really make this measurement effective. So the other way that we can do this is through pressure half-time. We take 220 and we divide that by the half-time, and this will spit out a mitral valve area. The idea is that the rate of the transmitral flow decline is inversely proportional to the mitral valve area. So using this formula, we're able to take an estimate. This is obviously not a direct measurement, so it's easy to obtain, but it depends on a number of factors, LA compliance, if aortic regurgitation is present. So there's knowing the limitations to whatever measurement that we're presenting. Then mean gradient, again, mean gradient is calculated through the Bernoulli's equation. This is very easy to obtain. It involves tracing, again, the CW Doppler that's obtained during our classic echo. But it depends on heart rate and flow conditions. So whenever you're reporting mean gradient, very important to report a heart rate, as this, depending on where the heart rate is, can really impact what the gradient we're getting, especially again in these patients that are prone to atrial fibrillation. Sometimes they need to think fast. And then systolic pulmonary artery pressure is another value that we look at. The systolic pulmonary artery pressure is usually sort of estimated as the RVSP, assuming that there's no RVOT obstruction. This is sort of a reasonable assumption. And it's the sum of the right atrial pressure and the maximal gradient between the RV and the RA. So it's quite easy to obtain, but again, it doesn't really estimate pulmonary vascular resistance. So I think just important to know that each of these has some advantages, has some disadvantages, and important to know what we need to report and what we need to think about when we're looking at them. So going through how to measure them and how to get them. So planimetry, like I said, this is the 2D short axis. You look for the smallest orifice area. It's very important to scan from the apex to the base to make sure that you're actually at the level of the valve and making your measurement sort of in an appropriate spot. You trace the contour of the inner mitral orifice. Again, MS diastolic murmur, so measure during mid-diastole. And if you're in atrial fibrillation, I think it'd take multiple measurements so that you can take an average of those measurements. Next is the mitral flow. So like I was saying, you take a continuous wave Doppler, typically best in the apical windows, whether that's apical 2-chamber, apical 4-chamber. Typically it's the 4-chamber. And then from this mitral flow, we're able to trace it, get a mean gradient. We're able to get the pressure half-time as well from the descending slope of the E wave, which we then use in our formula to estimate the aortic valve area. Systolic pulmonary artery pressure, like I was saying, you take the continuous wave Doppler in multiple different views. Really, you're looking for the biggest sort of tricuspid regurgitation signal. And there's a number of different views in an echo where this can be found. But really, wherever you're getting the peak, the highest signal, the most dense signal, this is the one to take. And then from there, you then get an estimate of the right atrial pressure with your IVC assessment and your subcostal views. And then again, like AS, very important to look at valve anatomy here to get a sense for what might be involved. So your parasternal long axis and short axis are really the best views for this. Is you can be fairly confident in looking at the anterior and posterior leaflets. And you're looking for valve thickness, pliability, calcification, looking at the subvalvular apparatus, anything that might be driving the MS, whether that's chordal thickening, fusion, or shortening. So going through that in a little bit more detail, we have our top kind of row here looking at our parasternal long axis views. We have our anterior and posterior leaflets. And then classically, if you're on plane, A2 and P2 is usually what you're looking at in this view. The short axis is very helpful because not only are you getting a look at the anterior and posterior leaflet, but then you can be very confident in which sort of segments you're looking at. And they're labeled sort of left to right, A3, A2, A1. P3, P2, P1. And then just recalling the mitral valve apparatus, although really in this case, just seeing leaflets, there's a number of things that are involved, whether that's the pap muscle, the cords as well, to think about what might be leading to the valve lesion. And this is not only important for mitral stenosis, but also mitral regurgitation to really have a good sense for the valve anatomy and what might be involved and what fix might be required. Rheumatic MS, I'll just show briefly here. It's helpful to really look at sort of an actual video of this to see the valve opening, as the classical description is that you have aortic, an anterior mitral valve leaflet doming, this hockey-shaped stick here, which we can start to see here where it's not really extending out, and then the posterior leaflet will be restricted or almost totally immobile. So when we're seeing this picture, really keep in mind rheumatic MS and interrogate well. Again, in our very first shot, the parasternal long axis, you can also look to see if there's evidence of mitral annular calcification, and then our short axis, grade the severity. And if we're seeing very severe mitral annular calcification or moderate, then a good idea to move on with interrogating that valve in a little bit more detail to make sure that there's no kind of MS present. Ultimately, in terms of the grading of MS, once we're able to get these measurements, then we're left with these sort of categories. So I'll draw your attention to severe, as this is typically when we're really worried about intervention. So mitral valve area, again, less than 1, a mean gradient greater than 10, and then our RBSP, or systolic pulmonary artery pressure, greater than 50, are all very important cutoffs that we're looking for in terms of severe MS. And I'll just go through some pictures here that kind of show what I've been talking about the last few slides. So this is, again, our parasternal short axis. This is showing the planimetry, tracing the mitral valve orifice to then get an estimate of the aortic valve area. Like I said, very important to pan through at this point from base to apex to make sure that we're tracing at the best possible point so that we're not overestimating it. Then our mitral valve pressure gradient, so again, taken as a continuous wave Doppler, through the LV and LA. And what we're looking at here is then tracing this so that we can get not only a mean gradient, but then from the slope of the E wave, we're able to get a pressure half time, which can then be used for estimating the aortic valve area. And then, as I was saying, for the systolic pulmonary artery pressure, it's really an estimate of our RVSP here. So we can see here they've taken a signal of tricuspid regurgitation. You get the max velocity from this signal here. And then our subcostal view gives us an idea of our IVC. Important numbers to remember: greater than 2.1 centimeters is plethoric. If it's with inspiration not dilating more than 50%, then this enters into sort of severe category and high RA pressures, which is normally estimated at 15. Conversely, low is less than 2.1 centimeters and greater than 50, and also greater than 50% collapse with inspiration. And that will estimate our 3. And if we have one of the two, then we're in the 8 category. So moving right along to sort of our last lesion that I'll talk about is mitral regurgitation. Again, mitral regurgitation, just like aortic regurgitation, I think a good way to divide it: acute and chronic. Acute, typically unstable. What we could be looking for ischemic causes, whether you've had a papillary muscle rupture, sort of acute endocarditis, acute trauma that's leading to damage to that mitral valve apparatus can lead to MR. More chronic, we look at primary and secondary causes. So primary it's actually affecting the valve itself. And like I said, there's a number of components to the mitral valve. So the leaflet can be involved in, if it's myxomatous, it might have mitral valve prolapse, it might have rheumatic heart disease. The annulus could be calcified. The cords could be involved in infection, trauma, just idiopathic, or the pap muscle, again, could be involved in trauma as well. All of these features can be involved in sort of primary chronic MR. And then you have secondary functional. And normally the classical description of this is that you have some sort of dilated, either ischemic cardiomyopathy or non-ischemic cardiomyopathy that leads to dilation of the left ventricle, that then pulls the pap muscles and the cords and leads to leaflet tethering, pulling the leaflets towards the apex, leading to annular dilatation, leaflet malcoaptation, and then ultimately regurgitation. So I think especially important to sort of have a good understanding of primary and secondary in this case, because the indications for replacement or repair depend on what sort of category we fall into. So primary, really the goal is to correct the mitral regurgitation before the onset of systolic dysfunction. So if you have severe symptomatic primary MR, irrespective of the LVEF, this is an indication for replacement or repair. Similarly, if you're severe asymptomatic, so even if you're not having any symptoms, but you sort of begin to have signs that your left ventricle is beginning to remodel, either dilating, functions dropping, this is an indication for repair or replacement. And then secondary MR, really the goal is to maximize goal-directed therapies, because the cause of this is normally heart failure of some cause, so getting them on all of their good goal-directed therapy, then reassessing the MR. If the MR is really refractory to medication, still causing a number of symptoms, there's no real class 1 indication for surgery for secondary MR. But we see here, obviously, TMVR, mitral clips can be considered in a severe MR that's really refractory to medical therapy if the anatomy is amenable. I think good to go through this as well, the Carpenter classification, just to have a good sense in that very first shot of the valve when we're seeing a shot of MR, to get a sense for maybe what category we're falling into. So the Carpenter classification looks at whether or not there's normal leaflet motion, excessive leaflet motion, or restricted leaflet motion. So normal leaflet motion, the leaflets are moving fine, but you still are seeing MR, then you have to start to think about maybe the annulus is just dilated, maybe there's a perforation in one of the leaflets, it's leading to regurgitation. Next, in the type 2, looking for excessive leaflet motion, you'll begin to maybe see a prolapse, maybe a flail. The leaflets might look myxomatous in this case. Can point you towards sort of a potential cause. And then in the restricted leaflet motion, so when there's thickening or fusion, tethering, in this case we're seeing tethering at this point with the LV dilating and then having that coaptation gap that's leading to MR, then we have a whole other sort of differential for this. So important in our very first shot to get a sense for what might be causing it. You'll see that this chart's similar in some ways to the aortic regurgitation chart in that we have specific and supportive qualitative features that we look for, and then quantitative parameters that can be really helpful in those borderline cases. So the specific signs that we look for, again, looking at the jet width, in this case, we estimate it relative to the left atrium. If it's less than 20%, more mild. If it's more than 40%, then we're into the more severe category. Look at the vena contracta. Again, if it's small, less than 0.3, if it's higher or more than 0.7, we will move into the severe category. We can look for the flow convergence as well. And again, we have different diameter cutoffs for this. And then in this case, we're looking for also that we can interrogate the pulmonary veins with a pulse wave Doppler. And really, if we're seeing systolic dominant flow, then this points us towards this could be just mild MR, versus if we're actually seeing systolic flow reversal, we'll call MR systolic murmur. And if we're not having blood flowing out of the pulmonary valves, it's actually going backwards, this can be a sign of severe MR. Obviously in the 2D echo, it's difficult to interrogate all the pulmonary valves, so that normally you can get hopefully at least one to have a good sense for whether or not this feature is present, especially if you can catch a good signal of it. Other supportive features, so similar to AR, you can actually look at the signal, the jet density of that regurgitant volume. If it's soft, parabolic in shape, this points towards more mild. If it's very dense, triangular shape, this points us towards severe. And then you can also look at the inflow itself, which classically is used for diastology, but looking at whether or not it's E dominant or A wave dominant can give us a sense. So mild MR, typically an A wave dominant feature, versus severe, we have an E wave mitral inflow. And then again, we have our regurgitant volume, regurgitant fraction, and EROA, slightly different cutoffs. So regurgitant volume is the same, it's 60 millimeters per beat. But our EROA, notice, is a little bit higher in the case of MR than it was for aortic regurgitation at 0.4 as opposed to 0.3. Again, I think really useful is using a calculation for this so that you know that you're not kind of confusing the two. So we'll go through some of these in a little bit more detail now. So first we'll talk about is really jet width and flow convergence. So here what we're looking at is we're looking at apical views. If it's mild central, we see here not really taking up much of the LA. This fits with mild. This is severe central, taking up essentially all of the LA, fits with more severe. Sometimes it's an eccentric jet, especially if you have a mitral prolapse or flail leaflet where you're getting a jet directed really anteriorly or posteriorly. These are difficult to interrogate, as it's tough to get a full Doppler signal of them. Sometimes it's tough to get a piece of them. So just important to note that when this is present, I think it's really important to really take an even extra close look to see if you can quantify it effectively. And like we did for the aortic regurgitation, really the vena contracta is the narrowest point. The flow convergence is really at the pisa point. Again, mitral regurgitation, systolic murmur. So we're measuring during systole, mid-systole. You can take this at a number of different views. Normally the apical 4-chamber is the best because you can open up the mitral valve, but you can do it in a 2-chamber as well. Sometimes even your 3-chamber if you're able to get a shot really wherever you're getting the best signal for measurement. As the vena contracta is not only a point that we can look at for severity, but when we see a vena contracta, important to then look for if there's a good pisa that can be measured for quantitative purposes. This shows our pulmonary vein pulse wave Dopplers. So again, this is done in our apical 4-chamber. We put our cursor and our pulse wave directly over the pulmonary valve. And we see here in normal, you've got flow forward during systole and during diastole through the pulmonary vein. In more modern MR, we start to see maybe a bit of blunting of the systolic flow, which makes sense. That's when we have our regurgitant volume coming backwards, and then more of a dominant diastolic signal. And then in severe MR, we've totally seen it here. So now we have a signal going in the opposite direction during systole, and then during diastole, a much bigger signal. So important to look for, again, not always able to get the best signals of this on transthoracic, but I think always a good idea to include in your assessment when you're seeing MR, because it can be quite helpful. Like I said, jet density really, again, same as aortic regurgitation, proportion to the red blood cells that are going backwards. So if you're seeing parabolic, less dense signal like this, then probably more closer to mild versus a triangular, really dense signal. We start to think about severe regurgitation. And then this is our E and A wave that are taken again, this case not with a continuous wave, but with a pulse wave Doppler that we do for diastology. In this case, we say an A wave dominant flow pattern. So this points us into more of a mild MR. Conversely, an E wave dominant, the E wave would be bigger than the A wave. And this points us more towards severe MR. And then just like aortic regurgitation, we have our quantitative calculations for this. It's calculated the exact same way. You need a PISA, you need a lesion velocity, and then you need to trace the signal of the mitral regurgitation so that you have a VTI and so that you have a peak velocity so that you're then able to calculate an EROA and calculate regurgitant volume. And again, these can be quite helpful. So just like aortic regurgitation, this is a really helpful sort of summary slide that goes through everything that we just talked about. I think the same principles apply in this case. Really look for your first run through, looking for qualitative features that may point you in one direction. If it's a slam dunk after that, then you can go forward with that. If it's borderline, do your quantitation. And then if it's moderate or severe, important to quantify anyway so that we have a good sense for how things are changing. So I know we covered a lot today. In terms of sort of summary and take-home messages, I think that one thing I want everyone to remember is just grading severity of these valve lesions is so important because it has clinical implications for our patients in terms of when interventions are offered and really closely monitoring how that disease process is progressing so that we have a good sense for when to get them involved with the proper teams for possible repairs, replacements, and fixes. I think another good piece is at least going through this and after about 2 weeks in the echo lab here, grading lesions really requires a number of different features and multiple views to assess the lesion, multiple markers of severity. And we see that every valve lesion we looked at, there's many different markers that we look at. And really no one should be used in isolation. I think it's important to look kind of holistically to figure out what category you're in. Quantification tools can be really helpful in those moderate severe. I think then it's really also important to recognize other features that may be impacting severities for each markers and reporting those. So in mitral stenosis, when you're reporting a mean gradient, you need a heart rate because this could explain really like why there may be changes in the gradient. Similarly with aortic stenosis, present a stroke volume. And then I think anytime we do see a pathology, it's really important to then take a close look at anatomy, take a close look at the patient to really begin to think about what the underlying cause is, as this may have impacts on really what the best treatment option is at that point. Clues might be the anatomy of the valve itself, the LV function, and then even the age and demographics. So that's everything I have for you guys today. Thank you so much for listening.